First, I want to thank the Samsky team and Julie for inviting me to speak today at this kind of Lunch and Learn revamp. And a special thanks to our entire Samsky team for being just great colleagues and providers. You know, for those of you who don't get to work with the Samsky heart failure team on a regular basis, I wanted to take a moment to really applaud them for their effort in the care of our advanced heart failure patients, our VAD patients, and our transplant patients. We as physicians, surgeons really can't do anything that we do without them, and I really appreciate everything that they do. So with that, we're going to get started. So as you can see, today we're going to talk a little bit about kind of new developments in LVAD therapy. And for those of you who are listening on this webinar who are maybe not taking care of these patients on a daily basis, I'm going to spend a couple of minutes kind of talking about what is an LVAD and going over the basics. And then talk a little about the evolution of durable devices over time and how that has changed how we look at the data as well. And then we're going to dive into kind of some of the new data surrounding LVADs. And I'll be honest here, there's a lot of stuff that we could have focused on, but I've chosen to focus on the things that I find most interesting, and I hope you do too. And then the last thing I'm going to talk about is kind of two things that I think are occurring in the near future as well as hopefully in the not too distant future. One of them is clearly kind of a now and about to happen, and the other one is somewhat pie in the sky, but I'll leave that as a teaser. So with that, we'll get started. So every presentation like this has to have some sort of obligatory disclosure slide. So for those who want to know, I have no financial disclosures here. Sometimes I'll make some mention about management recommendations and whatnot for VAD patients, but these are really general guidelines. Every single patient is unique, and how we manage each patient is determined by the entire clinical management team. So if I say anything in terms of INRs or blood pressure, things like that, you got to take that with a little bit of a grain of salt. Okay, so what is an LVAD, right? So in essence, it's a water pump for the heart and the body. And when we think about the nomenclature around LVAD, there's kind of two main terms that we typically use. One is an LVAD, which is a left ventricular assist device, but it's also known as an LVAS, or a left ventricular assist system. And these two terms are really used essentially interchangeably, although the most common term we use nowadays is LVAD. Remember that LVAD is a subset of VADs, right? So you can have an RVAD, which is also a type of VAD or a ventricular assist device, but this whole talk will focus on durable LVADs. And regardless of the system or the manufacturer who makes the pump or the device, there's essentially four main components to the LVAD. So the primary part that we all think about is the pump itself, which usually has an inflow, as you can see here. I hope, yes. You can see here that there's usually inflow from somewhere in the heart. Typically it goes from the LV apex and then out to the aorta, although there have been some devices where it goes from the left atrium or other parts of the heart out to the descending aorta or other arterial structures. Then, of course, you got to have some sort of power cord or pneumatic drive line to actually drive the pump that goes from inside of the patient to outside the patient. You have to have a controller that actually controls the system. And then you got to have batteries or wall power that run the system. So these are kind of essentially the main components of any kind of LVAD, again, regardless of what the manufacturer is. So then as we think about LVADs and we look at the data later on in this talk, I think it's imperative that we take into consideration who's getting these pumps, right? We don't put LVADs in healthy marathon runners. They're really going into patients who are quite sick. And the indications for an LVAD implant or the patients who get it today are really based on data that's been generated for the last several decades, which have really established the criteria for who can or should be implanted. And so the typical kind of inclusion or considerations are for patients who have class 4 heart failure or class 3B heart failure, people who have failed optical meta management for the last basically month and a half, peak VO2, which is a marker of how bad their cardiac output really is or cardiac index is, and then having a lowered ejection fraction. And there are caveats to all of this because just because you don't have a low EF, you could have a low cardiac index. So these are kind of the generic inclusion criteria for a VAD. But for everybody who, again, is not familiar with LVADs and how we make these decisions about who gets an LVAD, suffice it to say that decision is not a yes-no decision that's easily made. I mean, we have a huge team that really, hats off to them for doing deep dives into all these patients that really helps us decide who is benefited with an LVAD and who is not. And so really the decision about who should get a VAD or not is really beyond the scope of this lunch and learn, but maybe worth another one in the future. Okay, so as we think about LVADs over time, you know, the birth of LVADs actually started many years ago. And some would argue that it probably started the minute people started developing the heart-lung machine back in the 1950s. But really, I think others would cite the late kind of 1960s and 70s, which is really when there was kind of government-funded initiatives to start development in LVADs. But clinical utilization of LVADs really didn't start until the 1990s. And the first generation devices were huge temporary devices designed to get people kind of to the next step. So what I consider kind of pre-implantable LVADs were pumps that sat outside of the body with tubes that went into the body, and these were pretty much all kind of pulsatile pumps. This then led to really our first generation of true destination therapy or go home, leave the hospital kind of heart pumps. And really the workhorse or the industry standard that set the stage for this was the HeartMate XVE. So this was a pulsatile pump, very big device, probably about this big, give or take. And it was a device that when I was in my training, I actually took care of a few patients who came out with this device as a bridge to transplant. Fast forward, this device for a few years, the next generation device, which was really our workhorse device for, gosh, probably close to a decade, were the axial flow devices, or specifically the HeartMate 2. And many people in the room, I'm sure, will recognize this device because this is what we had used for a long time. And for me personally, pretty much my entire cardiac surgery training as a fellow, and then being at Duke, then being at Nebraska, was really centered around using the HeartMate 2. It had been the workhorse pump for a long time, until we got to our current generation devices, which are centrifugal flow pumps. So again, both these last two generations are continuous flow pumps. One uses an axial flow like a turbine, and the other one uses a centrifugal flow pump like what we use in our heart-lung machines. And this has really become, the centrifugal pumps have really taken over as the mainstay device for LVAD therapy. And it'll be curious to see kind of what happens in the future, because I think personally, and we can have a discussion about this later, the centrifugal device pumps have gotten better, but really the next thing for us is going to be getting rid of the driveline. What's interesting as we look at the kind of evolution of LVADs over time, we also see an evolution in kind of how the data has been looked at. So the pre-implant, early implant LVAD research trials and studies were really focused on just feasibility. Like, is this even possible? Survival was kind of measured, in days and maybe in weeks. And it started to define, some of the risks and things that we associate with LVADs. The Generation 1 pumps, like the XVE and the Rematch trial, really started to focus on survival, but it was survival against medications, right? Because at that time, we didn't have another pump to compare things to. We were comparing pumps to standard medical care, which were really just the best medications we had at that time. But once the Rematch trial was done and the XVE was proven to be better than medication, the future trials that we've done or have seen really never had a medical control arm because it was thought to be unethical. So the next generation pumps, these kind of axial flow pumps, started to have pump versus pump research trials. So not just the axial flow, but also the centrifugal flow pump started to look at HeartMate 2 versus the HVAD, or HeartMate 3 versus the HVAD. And these led to pivotal trials that I think have really defined kind of how our field has evolved over time. But it's interesting to see that if you go back 30 years, it wasn't about like the bleeding and the stroke. It was all about, can this person just survive? Today, we still talk about survival, but we're also much more focused on the side effects or the risk factors associated with all of these pumps. So this is kind of a history, quick review of some of the LVADs and kind of where we've been in the past. And so, going forward, as we get new pumps, we typically get more data, right? And so in this next kind of section of the talk, we're going to give kind of a little nod to the past, because I think it's really important to remember where we came from. Talk a lot about the Momentum 3 trial, and then talk about the INTERMAX registry and an update on that. So Maya Angelou said, you can't really know where you're going until you know where you've been. And I think that's especially true when it comes to understanding LVADs and how we evaluate them. So I've already talked a lot about, in the last slide, where we've been and how the data has changed. But I like to always kind of remember the big trials that kind of set the stage for where we are today. And the first trial that I'll make mention to, and if you ever want to read it, I've put all of the references in or all the links for references in the slides at the end. But the Rematch trial was really our first randomized trial that looked at LVAD versus medical therapy. and proved that LVADs were superior to medical therapy alone. And it established the criteria for LVAD implantation. And so to me, this is probably the most important historical randomized control trial for LVADs that's really set our field in motion. The next big trial was the HeartMate 2 bridge to transplant trial that started comparing HeartMate 2s to HeartMate XVEs. Again, another randomized trial that showed that we had a better pump compared to what we had before. And again, demonstrated that with technology improvements, we can get patient improvements. Another trial that I think is of importance, although in some respects historical now that this pump is no longer available, is the HVAD trial that also compared pump to pump, but was the first truly intrapericardial device to be used in patients for continuous flow. And so I don't use these trials to kind of hammer the past, but to kind of hopefully elucidate why we look at specific outcomes for LVAD patients now and in the future, which of course brings us to the most recent and probably the most important LVAD trial, the Momentum 3 trial. So we've talked about this trial in the past, and the trial started back in kind of 2013, 2014, with an expectation to have a randomized enrollment of HeartMate 2 versus HeartMate 3 with certain set points for review and publication. And one thing I think that's important, number one, is if you look at the authors of this trial, they are the kind of who's who of LVAD heart failure therapy. And if you'll notice in the middle of that, we have Dr. Dean and Dr. Krishnamurthy, who are both here, part of this trial. And Piedmont was actually one of the primary enrollers in the trial. And I have to talk to David about whether he was the first VAD in the trial or the second, but it was very early on. So Piedmont has had a big impact in this trial and pushing this field forward. So the reason why I put the Momentum 3 trial up is because the 2-year analysis was finally published at the end of 2019. And again, for those of you who are kind of unfamiliar with this trial, it was a randomized trial, multi-center, looking at HeartMate 2 versus HeartMate 3. And I'm sorry, I didn't dive into this before, but remember, the HeartMate 2 is an axial flow device. HeartMate 3 is a centrifugal flow device. They both are continuous flow, both made by Thoratec, that was then sold to St. Jude, now owned by Abbott. In this trial, they enrolled patients from 2014 to 2016 with an expected 2 years of follow-up, okay? Why 2 years? Well, 2 years because the rematch trial kind of looked at 2 years. And most trials since then have kind of focused on 2-year outcomes. I personally think, as a just an aside, I think going forward we're going to have to start looking at kind of longer term outcomes, 5, 6-year data, to really make sure that we're not just pushing off some of the risks for a couple of years. Regardless, that being said, the 2-year analysis has been done and completed. What was fascinating is at the 6-month mark, the HeartMate 3 was shown to be non-inferior to the HeartMate 2. Even at the in the 1-year mark, you started to see a signal that the 3 was getting better. But what's interesting is in this analysis, so at the 2-year mark, the HeartMate 3 showed a statistically better survival for patients to be alive without stroke or pump thrombosis, which is a big deal, for these patients. And you can see, while not everybody lives, you have a marked improvement in survival up to about 75% at 2 years. This is the best kind of 2-year data that we have for any pump up to this point. The other thing that was, I think, quite remarkable and noteworthy in this trial is that when you look at the adverse events, okay, so the HeartMate 3 is still a heart pump. So we still see issues like liver dysfunction, renal dysfunction, things like that. But what was striking is that at 2 years, there's a marked reduction in GI bleeding and disabling strokes for the HeartMate 3 pump. So again, newer pump, better outcomes. But the biggest thing that really drove the benefit for the HeartMate 3 over the HeartMate 2 from the beginning of the trial all the way to the 2-year mark is the risk of thrombosis for the pumps being so low. And this is really important. So we've always worried about clot forming on heart pumps because you've got this huge chunk of metal, sitting in a patient's body. And inevitably, patients have to be on blood thinners to prevent pumps from thrombosing. The HeartMate 2 initially had a very low pump thrombosis rate started to go up, and that kind of prompted the development of the HeartMate 3, which has a dramatically lower pump thrombosis rate. And this, so a lot of the benefit for the HeartMate 3 started out with the pump thrombosis rate being low, but now at 2 years, we're starting to see signals in other adverse effects also being reduced. So thus far, this would suggest that the HeartMate 3 is a superior pump to the HeartMate 2 at the 2-year mark. But after completing the enrollment for the main trial, everyone has this kind of argument that, well, this was a select group of patients at a select group of centers, and people were being super, just safe about who they're going to put in the trial, so naturally you're going to see this huge benefit for the new pump over the old pump. So after completing the enrollment for the main trial, there was a continued access protocol to allow continued enrollment for HeartMate 3 patients to be kind of followed and tracked the same way they had been in the main trial. So this paper, which was published in 2021, evaluated the outcomes for patients who got implanted with the HeartMate 3 after the trial patients were enrolled. And it's really supposed to be kind of the first representation of what is more real-world outcomes. And so as we go through this trial, there was 515 HeartMate 3 patients from the pivotal trial compared to 1,600 patients from the continued access protocol. And again, they follow these patients for 2 years. So now we want to compare what does the, quote, real world or post study population look like compared to that 2 years in a study population. And what we find is that even though the study was over, the patients who got implanted with HeartMate 3s still did just as well, if not maybe a little bit better than they did in the trial. And this was despite, if you look at the nitty-gritty of the data, right? This was despite the patients being maybe a little bit sicker, maybe a little bit older, and more kind of destination therapy than bridge to transplant patients. But I think this is important because it kind of validated a lot of the kind of question marks that people bring up from the Momentum 3 trial being, again, a very selective, scrutinized, randomized controlled trial, and comparing it to the first kind of real-world data and saying that, yes, the trial outcomes can be made real in real life. But the other thing that we get when we have a really nice designed and well-controlled randomized trial is it allows us to do an analysis of other kind of offshoots. So when the Momentum 3 trial was designed, it was actually designed with the idea that there were going to be several kind of subgroup analyses. So for example, there was one subgroup that looked at whether or not the designations that we have used in the past really made any difference. Excuse me. So when we implant LVADs, we typically have a strategy in mind. Some patients will implant LVADs with an intent to get them to transplant. Some patients, we implant them with the intent that they're going to live their life on an LVAD. And that's what we call bridge to transplant or destination therapy. And some people also use the term bridge to candidacy or bridge to recovery. So when the Momentum 3 trial came out, there was an evaluation done that looked at, is there a significant difference in the outcome of patients, whether they're implanted as a bridge to transplant or as a destination therapy? And what the authors in this study found, and again, published in a reputable journal, is that there was really no significant difference. So whether we labeled the patient as a bridge to transplant or destination therapy, it really didn't make a difference in terms of how they did at the 1 and 2 year mark. As a consequence of this, as well as other kind of ideas, thoughts, criticisms, discussion, there's been a recent change in the Medicare coverage decision to remove those prior definitions. So when we used to use terms like destination therapy for a patient who's expected to live their life on an LVAD, we now use the term long-term therapy versus short-term. And this makes a lot of sense, right? Because there are some patients where we implant them for an LVAD because they're sick. Their pulmonary pressures are high, their kidneys don't work, and we implant them under the definition of destination therapy. But they will oftentimes switch back to a bridge to transplant if their kidneys recover or their lung function gets better. So the idea of short-term versus long-term aligns better with kind of how we think about how long the patient is going to be on an LVAD. So this was one example of something that came about from the Momentum 3 trial. Yet another, I think, focus of the trial, because for us as clinicians, we know that infections are a major adverse event and kind of a drag on patients. So another thing that was kind of focused on in the Momentum 3 trial was also infections overall. And this paper, which was published a year and a half ago in the Journal of Heart-Lung Transplant, looked at all of the infections that happened in the Momentum 3 trial. And what was fascinating is that the vast majority of these infections were not related to the pump or the driveline. In fact, only about a quarter of the patients actually had driveline related infections. Again, 3/4 of patients, maybe a little bit more than half, somewhere in that range, had infections related to urinary tract issues, bloodstream from other devices, whatever else it may be, that they weren't all kind of driveline related problems. And most of these patients died really from not their infection, but from other causes when they did die. And I think this paper brings to light a question about whether it's really the VAD that's causing these patients to get infected, or are these infections occurring in patients who were already predisposed for infections. And the reason why this comes up is because the infection rate was quite similar between the HeartMate 2 and HeartMate 3. So I think the Momentum 3 trial really, in my eyes, has been a very important trial to give us a lot more kind of new world data on new devices, how we look at it, how we track it. And there are other trials that I didn't go into that came out of the Momentum 3 looking at stroke, looking at management and other kind of facets of the HeartMate 3 that we can kind of discuss offline or other times. But it was a great trial. Clearly, we're still going to get more data from it, but it is the most important recent randomized control trial for LVAD therapy. Which brings me to real world information, right? So all of these trials, like I've mentioned before, are great when they're done in isolated centers. But what do we do about talking to our patients about what happens in our own center and that happens in the real world? So for people who are listening out there who are not really familiar again with LVADs and the VAD world, the INTERMAX database is a national database for LVAD implants. And pretty much all LVADs that are implanted in the country are logged and tracked in this database. And every year there's an update that's published. And I thought it was germane to this talk to review the newest data for two reasons. Number one, this update just came out towards the end of last year, and the primary author is actually going to be joining the Samsky team here in a few months. So in this update, the registry was reviewed for the last essentially 10 years. So January of 2010 through December of 2019. And the registry itself will also follow patients who have total artificial hearts, RVADs, or other kind of strange devices. But again, to focus solely on the kind of primary modality of VAD support, they focused on isolated continuous flow LVADs. So during this kind of 10-year time period, there was a little over 25,000 implants. Excuse me. And they divided these first into the axial flow device, which is essentially the HeartMate 2, a hybrid device, which is an HVAD that was originally designed by one company and then recently bought by Medtronic, and then a maglev centrifugal flow device, which is the HeartMate 3. And what you see that I think one of the findings that's interesting in all of this is in 2010, you can see here all of these patients, were HeartMate 2 implants. And for several years, we saw this kind of steady rise in VAD implants. And it's a little bit hard to see, but this little arrow right here, in November of 2012, is when the HVAD was approved for bridge to transplant. And I think this graph and this database really demonstrates how we as clinicians and surgeons can quickly adopt new technologies once we know that things are proven to be of benefit. So you can see here in 2012, the HVAD was approved. In 2013, all of a sudden, not quite a quarter, but probably a fifth of patients got that device. And then slowly it started to take, a little bit more kind of market share from the HeartMate 2 device. Until you hit, 2017, where the HeartMate 3 was then approved for bridge to transplant. And more importantly, the next, in 2018, when it was approved for kind of everybody, you see this dramatic increase in the use of the HeartMate 3 device. What's interesting is in June of 2019, the FDA actually issued a recall and a stop using, whatever the right term is, for the HVAD. And so although there were a fair number of HVADs implanted in 2019, that really represents about the first half of the year. And I suspect when we get the next INTERMAX report, this bar right here will be gone. It will be almost all HeartMate 3 with a few HeartMate 2s kind of here and there. So another interesting finding, from the survey, it's not directly related to the LVADs, but I think it provides an interesting commentary on the impact of heart transplant listing on LVAD strategy. So what you can see here is that when for many years, the number of patients who were implanted under a bridge to transplant strategy, and again, remember, that's kind of a little bit older terminology now, but then, and even up to the end of this, time period, it was still the same terminology. But the number of patients who were implanted as an LVAD with the anticipation they were going to get a transplant, hovered in the kind of 18 to 20, 25% range, with other patients kind of in a destination or a bridge to candidacy range. In 2018, UNOS changed their listing criteria, and they changed it in a way that stable LVAD patients now got pushed down on the transplant list. And it really changed how we strategize putting LVADs in patients, such that fewer patients now are getting LVADs as a true bridge to transplant strategy, and more of them are getting implanted as a destination or a bridge to candidacy. So I think, again, this graph itself doesn't really speak to LVADs per se, but I think it does speak to the interaction between LVADs and heart transplantation. But the real impact of these databases, in my opinion, is to guide us as clinicians and providers to educate our patients on expected real-world outcomes. And what's noteworthy, as demonstrated in this graph, which is the survival graph, is that even from one era, so this red line here demonstrates the kind of early era of this review, and this other line here demonstrates the later 5 years. And you can see that that with real 5-year data, we're actually having still an improvement in overall survival of patients. So now we can actually tell patients that, hey, if you get an LVAD today, you have a almost 50% chance of survival at 5 years. And the 2-year survival, 73% is still quite impressive. And remember, you have to compare that to what is their 2-year survival and 5-year survival without an LVAD. For the patients who are getting these devices, those 2 and 5-year survivals are typically measured in the single digits, if not, 0 at 5 years. So this is a dramatic, I think, representation of what we can tell our patients they can expect from a survival standpoint. But survival is not everything, right? So as I tell all of my patients prior to being considered for LVAD, there's a big difference between being alive and living. And so I think it's important that we always keep in mind the risks and complications of these devices. So beyond survival, every LVAD center in the country follows kind of 3 major metrics. The first one is infection. And so once again, the INTERMAX database has shown us that at 1 year, about 40% of patients will experience some sort of infection, but only about 10% of those are device-related. So this includes things like pneumonias, urinary tract infections, whatever else it may be. But I think it's important that we tell our patients that they got a 40% chance of getting an infection within the first year. Another outcome that we track very closely for all of our LVAD patients is GI bleeds. And what's remarkable is that the GI bleed rate at 1 year is 20%. That actually is a marked improvement from what I was always taught as a resident and a fellow, where we would quote patients a GI bleed rate of 30 to 35 to 40% in the first year. What I think is more striking in this INTERMAX update is that 60% of patients have no GI bleeds within the first 5 years. So yes, it's true, 40% of patients will have some sort of GI bleed, but that still means that the majority of patients are free from these issues. And then the last thing that we look at is stroke. And the stroke rate for LVADs still remains significant. It's over 10% at 1 year. But again, like the GI bleed rate, it's almost a 70% freedom from stroke at 5 years. So while that stroke curve is kind of high in the first year, it tends to kind of stabilize out over time. And the last thing that I think was an interesting finding in this paper, which I didn't throw up here because it gets a little bit confusing, and it's a little bit morbid, is looking at why patients die. So in the early era, a lot of patients were dying from infection, stroke, other problems like that. And only about, I think it was 5 or 6% of people were dying because they chose to turn their device off. What we're finding today is that patients are living longer, and as a consequence, they're getting other conditions like failure to thrive, debilitation, which are allowing patients to then choose themselves to turn their VAD off. I actually had a patient just a couple of weeks ago who had done really well on his VAD for about 2.5, 3 years. He was now 76, 77. And was kind of failing, was in the hospital more and more, and he actually chose to go home and turn his VAD off and live his days with his family in a comfortable environment. So what's interesting is that 10–15% of people now are living long enough with their VAD that they're having other things that they ultimately choose to just turn their VAD off, but they've gotten years of good life prior to that. So one topic that's kind of a hot topic, nowadays, of course, is COVID, right? We all want to know, how does COVID interact with the things that we treat, or the people that we treat, or the diseases that we manage? And if there's one thing that I can tell you, is that LVADs plus COVID is bad. And it's worse than a non-VAD patient getting COVID. So when the COVID pandemic first started, we didn't really know what the ramifications, would be to an LVAD. But we had some concern, right? LVAD patients represent a compromised patient population. They all have heart failure. They all have comorbid disease. They tend to be older. There is some risk of clotting and bleeding in these patients because they don't have pulsatile flow. They have continuous flow. They, again, have all these other comorbidities. And another big concern, at least that I had, was that when patients got COVID, what was that going to do to their pulmonary system, their pulmonary pressures? Was that going to induce RV dysfunction? But another thing that was kind of funny or really hard to kind of understand is, how do you manage an LVAD patient when you can't see them in person during clinic visits? And so we kind of faced a lot of these things, and I'm not going to dive into all the data because, unfortunately, when we look at the data and try to see how does COVID and LVAD interact, most of the data really is just one or two kind of case series or single center reports that don't really dive into kind of really the nitty gritty. But suffice it to say that the mortality rate is pretty high. So if you have an LVAD patient who gets COVID and gets admitted to the hospital, they are facing an 8 to 10, maybe even 15% mortality. So they're going to die, from that COVID infection. There's also a couple of reports that demonstrated an incidence of higher pump thrombosis and strokes in patients who have VADs and get COVID. And I think, again, I didn't dive into all of these studies, but I think one thing to keep in mind is that the LVAD patient who gets COVID is a very unique patient population that really requires close attention and aggressive treatment. And I've been telling all of my patients to get vaccinated as soon as they, either recover from surgery or as soon as they can before surgery. And so this is kind of the newest, thoughts about COVID and LVADs. Ultimately, yeah, COVID plus VAD is bad. And we've actually had a few patients who've been readmitted with COVID. We've had at least one person who passed away ultimately because of the COVID, despite doing great from their LVAD. The next, kind of topic of interest that I have is the smaller pumps allowing for new ways to implant them. And I think a big thing that's coming about in the literature is this concept of less invasive implants. So I think this is a kind of an interesting approach for implanting LVADs. And it's considered to be kind of less invasive, but it really should probably be called a mostly sternal sparing surgery. So the way this kind of less invasive approach is done is it's usually 2 incisions, sometimes 3. So there's a small incision or a moderate size incision in the left chest, usually between the kind of 5th or 6th interspace, depending on where the LV apex is. You go between the ribs, spread it, and you get access to the LV apex. And then you get a second incision up near the top of the sternum, either through the top of the sternum or between the ribs on the right side. And the way this is done, we go on bypass, or people go on bypass usually from the groin, sometimes centrally. And you put the LVAD pump head in through this incision, and you pass the outflow graft kind of behind the sternum up to the ascending aorta, and then stitch the aorta, the aortic anastomosis. And then you tunnel the drive line out, somewhere else. And voila, you're done. And as you can imagine, there are clearly, some kind of pros and cons to this approach. So on the pros side, people have suspected that, well, maybe it leads to less bleeding, a little bit faster recovery, maybe by not disturbing the sternum, the right ventricle will be better. But there's also real cons to this approach. You cannot address the tricuspid valve through these kind of incisions. The mitral valve is also question mark. How about the left atrial appendage? And it turns out that when you look at the literature, about half of our patients who get an LVAD need some sort of valve work done. But then what does the data say, right? Like, this is a good approach, but do we have any real world data? And it turns out that we do, actually. People have been doing this approach now for probably 5 years, give or take. And the first set of data really looked at kind of case series. Again, feasibility, is this even possible? But I think this article that was published in 2021 was kind of the first meta-analysis that looked at all of the papers that kind of compared these two approaches, right? A full sternotomy, traditional LVAD implant against one of these thoracotomy minimally invasives. And this meta-analysis had like 1,000 people in it. 2/3 of them had a sternotomy traditional VAD implant, and about 1/3 of them had a thoracotomy approach. And what they suggested or found was that there were sicker patients who they thought, based off of just renal dysfunction, that were getting the thoracotomy. They claimed they had less RV failure, but the same number of patients requiring RVADs, less bleeding, and they suggested that there actually may have been less mortality as well. But there was a lot of criticism with this paper because, again, it's a meta-analysis of case series. So, for example, why did the patient who got the sternotomy get the sternotomy? Were they sicker? Did they need 2 valves done, which is an intrinsically different population of patients? And so, like when I saw this, or when my colleagues, other people I talked to across the country saw this, we all kind of said the same thing. It's like, is this really real-world data? So when we think about the real world, what do we turn to? Well, we like to turn to our tried and tested database, which of course is the Intermax database. So this article, which was published towards the end of 2021, did an Intermax review looking at the last kind of 4 years of LVAD implants. And they compared the traditional implants to thoracotomy implants. Now, what was interesting is across the kind of U.S., less than 10% of all implants were done through a thoracotomy. So that tells us 2 things. Number one, it's not as easily adoptable as just changing a pump. And number 2, maybe there's a little bit more thought about who really should get it. And what was good about this trial is they actually tried, instead of just comparing everybody to everybody, one group to another, they tried to do something called propensity matching, where they're trying to match risk so they can kind of compare apples to apples. And what they ultimately found is that there was really no difference in RV failure, no difference in long-term RV failure, no difference in survival up to 2 years, but the thoracotomy approach did have a little bit shorter length of stay. And when I read this, what I conclude is that it's definitely no worse. I can't say it's really better, but I think what we're going to find in the next couple of years is that there's probably a patient group where doing this kind of minimally invasive or less invasive approach is actually going to be better. But, time will tell. And as we speak about the future, what's on the horizon, right? I think the 2 big things I alluded to before was first, kind of changing some of our medical management, and the second one is, can we get a fully implantable pump? So, there's that phrase, the future is now. And so this is kind of what I was talking about earlier. The next trial that's ongoing right now is the ARES trial. And Piedmont and our whole heart failure VAD team is part of this trial as well. And the question that's being asked is, do HeartMate 3 patients need aspirin, right? So the rationale behind this is that the HeartMate 3 was demonstrating the Momentum 3 trial to have a really low pump thrombosis risk. Second, there was another trial that was done in 2020, again, looking at some of the Momentum 3 data, that suggested that there was really no difference in outcomes for patients who got low-dose aspirin versus kind of a full aspirin. And there's even been some anecdotal evidence to suggest that if you stop aspirin, you actually can lower GI bleed rates. So as a consequence of these things together, this ARES trial was designed as an international, multi-center, randomized controlled trial looking at new HeartMate 3 implants. And patients who get put into this trial are randomized to either receive Coumadin alone or Coumadin plus aspirin. And the main endpoint that we're going to focus on is what is their survival free of non-surgical kind of bleeding issues, right? So when we talk about hemocompatibility things, we're not just talking about bleeding, we're talking about stroke, clot, DVTs, GI bleed, head bleeds, all that kind of stuff at 1 year. So we are actively enrolling in this trial. I don't know offhand how many people we've enrolled, but every single HeartMate 3 we put in today, we ask the question, can this person be part of this ARES trial? Because I think this will really help us decide, is the aspirin now going to hurt them or help them? So this will be a fascinating kind of outcome that we get to look at in a couple of years. I think the next real kind of pie in the sky, but hopefully coming down and becoming achievable, will be a fully implantable LVAD. And the major advantage that we see to this is a reduction in driveline infection. But the other thing too is then patients can swim, right? So right now, if you get an LVAD and you've got a driveline, you can't swim, you can't take a tub bath, you can't get into a hot tub because you have this driveline that you have to take care of. And so the idea of getting a fully implantable LVAD is something that's been kind of, slowly being worked out over time. But there are risks to this as well, right? Because if you put the whole device inside, how do you access things like the controller? What about heat generation or skin damage when you're trying to transcutaneously charge an internal battery system? And what happens if one of the components inside, has trouble? But I think there's one company that seems to be close. So first, my disclosure, this is not an endorsement for this company. This is just an example because there was a paper that was published on this. So this paper was put out in 2019. It was the, quote, first human use of a wireless energy transfer device with a continuous flow LVAD. And as you can see here, this device is a fully implantable device, and they actually, what's interesting here is that the company that made this device made the charging system. They did not make the LVAD, but they coupled the charging system with a LVAD called the Jarvik 2000, and they implanted this. So the way this works is, you can see right here, this is the LVAD, and here's the drive line here that stays inside. And there's a coil that goes in the lower chest here that's charged by a transcutaneous system with an internal battery, somewhere in here. There is a backup wire that comes up here behind the ear in case the transcutaneous system has a problem or there's an emergent issue or whatever it may be. But again, proof of concept ideas, patients walk around without a driveline coming out of them wearing this vest that allows charging of this internal coil that then charges a battery that can then power the system. So do I think that this is ready for prime time today? No. But am I hopeful that this technology and other technology is going to be available in the next, hopefully, 5 years? Yeah, I think it's quite feasible. But the only people who really know are the Abbott people, so you may want to, ask them. So, in summary, LVADs have really come a long way in the last 25, 30 years. I think the outcomes slowly, continue to improve year by year. The HeartMate 3 clearly, I think, has superior outcomes compared to a lot of prior, VADs. They are approaching outcomes similar to heart transplant in terms of survival, but I think it's always important to keep in mind these adverse events, risk factors, and other things associated with LVADs versus transplant. I think the future for VAD therapy looks really quite interesting. I think every month, every year, every day, we start thinking about how do we manage these patients better from a medical standpoint. And over time, even with just medical changes, we've seen improvements in LVAD outcomes. And I think once we get to that next generation of fully implantable devices, it will probably be a true game changer for this field. Thank you. Yeah, so that's a good question. So the question was, would a lateral thoracotomy approach make a subsequent operation easier? So the short answer to that question is probably. So one of my buddies does a lateral thoracotomy quite frequently, and he also does transplant. And I've asked him this question, and he said that it makes, from a surgical standpoint, I'm not trying to get gory here, but getting through the sternum is easy. But everything within the pericardium is still quite stuck. So yes, it makes the bone incision a little bit easier, but it doesn't necessarily make any part of the rest of the operation any, less challenging. But I do think there was one paper that looked at blood use for the lateral thoracotomy approach. And there is a suggestion that those patients require less blood transfusions at the time of their VAD implant. That's important because it may play into, what happens with their HLAs and their candidacy for donor organs. So I think that's an important, kind of thing that we need to flush out. I think in today's day and age, with the advent of things like Gore-Tex, closing the pericardium, wrapping the LVAD in native tissue, getting back from the front versus the side, that there may be a little bit of difference, but I don't really personally think it's a marked difference.